We will be beginning in 2 minutes. Thank you. That works. Ladies and gentlemen, muy buenos días a todos. Bon dia, bonjour. Good afternoon. Good afternoon. Thank you. Ladies and gentlemen, in absentia, Madame Excellency Michelle Bachelet, may also recognize the head of GE's delegation, Ms. Terry Bresenham, Chief Innovation Officer for GE. May also recognize the Executive Director of Partnership for Maternal, Newborn and Child Health, Ms. Helga Vogstad. In the audience, we also have with us the representative of the WHO, Walt Johnson. Welcome. Distinguished ladies and gentlemen, members of the media, again, good afternoon. My name is Ambassador Neil Parson. I'm the chairman of the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, the G4 Alliance for short. The G4 Alliance is a network of over 85 implementing organizations to improve access to safe, affordable, and timely surgical care for all those in need. Our members help to support education, training, capacity building, institutional strengthening, service delivery, resource mobilization, research, advocacy, and innovation in over 160 countries around the world. Thank you for joining us this evening for an event that will shine a spotlight on the impact of safe surgical care for advancing women's health. We are honored, I recognized them earlier, but let me repeat it, we are honored to partner with the GE Foundation and with Partnership for Maternal, Newborn and Child Health to bring you an event that will celebrate the essential role of women as providers, as advocates, and as innovators. We will commit to investing in safe surgery as part of universal health coverage and as part of the Sustainable Development Agenda. It is timely that Dr. Tedros has prioritized gender equality as part of his platform as Director General and as part of the WHO's upcoming 5-year program of work. We are here this evening because we believe that supporting women's equality and elevating women and allies in the diverse roles they play, such as providers as patients, as advocates, and as champions of safe surgical care. Distinguished colleagues, around the world, nearly 5 billion people do not have access to safe, affordable surgical and anesthesia care. This leads to nearly 17 million deaths each year and countless more disabilities. And the reality is that women are often disproportionately impacted by a lack of access of essential services. You know, I often argue women are the pillars of our families. Therefore, they're the pillars of our communities. Therefore, they are the pillars of our societies. Therefore, they are the most catalytic force in incentivizing economic development in any society. Economic development, by its natural nature, ensures prosperity for all. And prosperity for all really creates a path for all our countries fulfilling their 2030 obligations to the global community, the Sustainable Development Goals. Secondly, I also feel without the catalytic nature of women in economic development, it becomes a national security issue. It becomes a migration issue. Sometimes we think surgical care, access to women having access to safe essential surgery. What does that mean? But in the long run, it's really securitizing the economic path for most of our countries. And the other issue I'd like to touch on very briefly, access to safe, essential surgery, in my view, and I'm not speaking on behalf of any government, in my view, is a basic human right. It is a basic human right. Madam Excellency, welcome. Pleasure to see you once again. Her Excellency, former President of Chile, Michelle Bachelet. A round of applause, please. We have a fantastic lineup of guest speakers today who share in our vision of a world where no woman or person will go without access to safe, essential, and timely surgical care. It is my privilege at this point to invite my friend, Mr. Gustavo Perez, a fellow board member of the Global Alliance for Surgery, Obstetrics, Trauma and Anesthesia Care, and he also wears the hat of President and CEO of GE's Health Imaging Guided Therapies. Ladies and gentlemen, please welcome Gustavo Perez.
Thank you, Ambassador. Welcome, everybody. I would like to extend the sharing of the belief, not only in the panelists, but I think everybody who is here, the belief that women play a critical role in the topics that we'll discuss tonight, as champions and as advocates, but also as providers, as innovators, implementers. So tonight, we are going to be having three main sections, discussions. First, we'll start with a conversation with obstetric and anesthesia champions, with Dr. Bisola Onaji-Nobembe and Dr. Laurie Romanzi. We'll have later on a dynamic tech talk on surgical innovations with Ms. Sherry Reynolds and Mr. Hannington Segrinia. I will have to finalize a very diverse and talented panel with Dr. Gawande, Dr. Edna Aidan, Ms. Terry Bressenham, former President Michelle Bachelet, and Dr. Mpoki Olisubija. And now, without further ado, I would like to introduce Dr. Bisola Onaji-Nobembe. Dr. Obembe is a consultant anesthesiologist and assistant professor of anesthesia at the University of Port Harcourt, Rivers State, Nigeria. Dr. Obembe also practices and teaches pediatric anesthesia, as well as anesthesia for maxillofacial and ear, nose, and throat surgeries, and she has publications in these areas. She has developed interest in team building, leadership, strategy, and organizational change management, of which she plays roles within and outside of Nigeria. Also, Dr. Laurie Romanzi. Dr. Laurie Romanzi is an OBGYN with 15 years global health experience. She has collaborated with colleagues, funders, and other stakeholders through Africa and South Asia, ranging from policy to clinical practice levels. I will invite you here.
It's a pleasure to be here today. I am replacing Barb Levy, Vice President of Innovations at the American College of Obstetrics and Gynecology, who unfortunately had a travel issue and will arrive too late to be here. I think it's safe to say, I'm preaching to the choir, women's health is undervalued and also far too often suffers from politicized agendas that create more roadblocks. And we won't meet the Sustainable Development Goals without fully empowering women's health care. Along with that, we have to empower women's leadership in the healthcare sector. Currently, I serve as a director of a USAID-funded fistula project at Engender Health. Now, fistula was eradicated in the global north in the early 1900s, a good 40 years before antibiotics were available, to give you a perspective of that time. And still, today, obstetric fistula is a threat for every single pregnant woman in the majority of the world. This is wrong. This is inequity at its worst and most egregious. And the way that you prevent fistula is with safe, affordable, accessible, high-quality cesarean section. So every day in this role, I'm frustrated by the persistence of global health inequity as it affects women. I can also say in my career, I've seen a massive shift. When I was finishing medical school in OBGYN, it was still very much a man's world. And at that time, it was around 20% of OBGYN residents were women. In my career, that has gone to the complete other end of the spectrum. And now we have, I think it's 82% of residents in the United States OBGYN training programs are women, and they're top of the class women. These are very competitive, top of the medical school class applicants. Still, we have a dearth of leadership in academia. We have a dearth of leadership in industry. And we also, actually, it's such an intense shift that just last month, our National Public Radio published a piece saying, maybe we need more men in OBGYN. I said, maybe we do, but let's let women come up and take those positions of power, because who better to understand OBGYN than women? And it affects how you train, it affects how you implement programs. And while men who are champions of women's health are some of my favorite people in the world, it still requires women in leadership roles. One of my favorite things about working overseas is that somehow that fades away. I don't know if it's because I'm from the US and I'm going into low and middle income settings, but my gender ceases to be an issue. I find that really quite a lot of fun. But I know when I work in Nigeria, I also see already a lot of women in the healthcare sector, and they seem to be in positions of academic power. But I'm wondering what your experience has been, Isola.
Yeah, thank you. My experience has been a little bit different because, in Nigeria, all the men, the male doctors and specialists left for Saudi Arabia, left for greener pastures, and so we have the women staying back, probably because they were married and they didn't have the kind of opportunity to leave the shores of Nigeria. So they were left behind to manage the crisis. And anesthesia, I'm an anesthesiologist, and anesthesia was not the priority career, in Nigeria. You want to be seeing gynecologists, surgeons, and, all the rest of it. Anesthesia, you're backstage. So it was left to the women. It was more like a feminist, thing. And so the women were the ones to pick up anesthesia, stayed at home and developed it. So that anesthesia in Nigeria became a feminine career. And it's until recently, with the intensive care, the gadgets, the technology, the men started coming into anesthesia. So it was a little bit different. But then it was, we were not respected like our male colleagues, until the men started coming into anesthesia and seeing. Initially, you think, oh, just put a face mask, put chloroform, and the patient will go to sleep. It's no big deal. And when I got into anesthesia myself, I thought, oh, it's no big deal. Just put the chloroform. Then I saw, or whatever it is, halothane. But then I saw that I had to see the patients, review, inspection, palpation, percussion, auscultation. I had to look at the physics of, the anesthetic machines, the laws. I had to look at drugs, intravenous drugs, gas laws, Boy's laws and all the rest of it, the gadgets, the physiology, the anatomy, So it's it was a challenge, really. But then, because other women had gone ahead to excel in it, we decided to own it and excel in it. But now we're having both male and female come in, and then, the nurses, just like the nurses, nurse anesthetist, he was like a feminine thing. But we all know that it's not a feminine thing. Now we have both sides coming into it.
It's true. Have you ever had the experience of the... Thank you. And have you had patients or their families say, where's the doctor? Have you had that?
Yes, because the first time they see you, they think, oh, well, you are a nurse, or, But then they get to know the difference, because once I think it comes with a personal touch. You doing your review and explaining, getting the consent, then they get to respect you. Then your colleagues also get to respect you. Because I've seen situations where the surgeon comes and says, I want this done right now. And I say, oh, fine. You're going to have a beautiful surgery, but then can we guarantee the life of the patient? Because post-operatively, we may run into challenges. So it comes with working as a team, explaining. Where you don't have the physicians to explain, then you have problems, because I want to do this case right now without optimizing the patient. So we need to, especially in a place like areas in Nigeria, rural areas, we need to make sure that we have capacity for anesthesia, build up capacity where there is no capacity, as well as teach the team what it's all about.
Exactly, yeah. Nothing worse than having to say that surgery was a success, but the patient died, right? Yeah. So mentoring, I think we should talk a bit about mentoring, because I found that to be a real gap as I was coming up. I felt very much until maybe the last 5 years that I was making my own way, and mentoring of women by men or women and mentoring between women is something I think women have a harder time being effective at. What do you think?
Traditionally, the medical profession has been that of the boss and the students, or the learner, or, you learn on the job. So it's been like that, but with time, it's been changing. For example, the program in Lagos University Teaching Hospital started with a woman who came from Canada, Professor Shirley Fleming, and she started this program and she mentored, people, And so that was how anesthesia developed in Lagos. So mentoring really is very important, but it gets to a point where it becomes a thing of, I'm the champion, I'm the big boss, and the kind of forget that you need to duplicate yourself. You need to have more, you need to teach more, you need to mentor others. You want to be the, you know, I'm the big fish. And so a problem was created where you had lone workers, you know, lone leaders, and then the crisis began. But now, I think we're realizing that there's a gap in mentorship, mentoring your colleagues, in winning residents, in getting new people into, I'm talking of anesthesia now, and sometimes other areas. So we need to, the leadership, letting people come, buying them over, winning them over right from medical school is becoming evident that we need to close up the gap and encourage more people to come into anesthesia. So it's really very important that we do that. Yeah.
One thing I've noticed in resource-constrained settings is that the best anesthesia services are reserved for the main operating theater. And the maternity, by necessity, needs its own theater so we can deal with obstetrics emergencies as they come up and not try to crowd the main operating theater. But anesthesia healthcare worker density is so constrained, it's much easier, I think, to deal with the main operating theater. And so you often see maternity underserved. We have many facilities that we work with through our project where the fistula surgeon is still putting in the spinal with no anesthesia monitoring whatsoever, not even a pulse oximeter. I know LifeBox is here somewhere. What's the situation in Nigeria? Is there an awareness of this or a plan for it?
With the World Federation of Society of Anesthesiologists working so hard to close the gap and raise awareness, because we have a World Anesthesia Day, and there's been a lot of reach out to other people to realize that this is an area where we need to train, where we need to reach out to the rural areas. Of course, I don't think an anesthesiologist, after training for 5 years, 6 years, will want to go to rural areas. So we do recognize that you have primary health care, secondary, and tertiary. So the tertiary, really, you have the consultant, the specialist there. That is their area because it's training, it's research, and it's service. But the secondary, the primary and the secondary area is where we need to train more people, the nurses and other providers, you know, so so that the service can reach those areas. But it has to do with policy and awareness and the will to train. And the one thing I always tell people is work-based training is very important. If you take someone from a rural area to the city, the person will not go back. So the best thing is scale up the services there, scale up the theaters there, invite people to come. Because if someone came from Canada to Nigeria to scale up services at the Lagos University Teaching Hospital, others came from Britain to Ibadan, University College Hospital, to scale up the services there, then it follows that if we do the same thing in the rural areas, get someone to go down there, scale up and say, this is the red line, this is how you sterile area, this is what you do, this is how to use this machine, and then develop the workforce there, you know, then things will improve. And I was talking earlier to Dr. Edna, and she mentioned something saying that they have a contract, they withhold they train them, and then when they go back to their local areas, you know, within 2 years, they don't give them the certificate until 2 years. And within that 2 years, they're settled. So there are different ways of making people stay back, you know, by reaching out, scaling up, because what do we want? We want all the infrastructure. We want things to work out. Give it to them, train them there, and let them own it.
So let's pull it back into the community before we end. I want to keep to time, and I don't know who's keeping time on us. Are we all right? We're good? Okay. In the United States, we have more or less a preventive healthcare model, and women overwhelmingly make the healthcare decisions for the whole family. So it creates a bit of an incentive for industry and the healthcare system to cater to women, because if they get good care for obstetrics and for gynecology before they become pregnant, they typically then will continue to bring their whole family into that healthcare institution system. But what is the situation in Nigeria? Is that happening at all? Or who controls healthcare decision-making in general in Nigeria?
It's multifactorial. It's different. From the north and the south, it's different. And it's based on the level of education and culture. Africa is a multicultural area. So the more educated the woman is, or women are, the more they seek medical care, while the ones who are not educated do not seek care. And then because they don't have jobs or it means a livelihood, they take it. We have a lot of very complicated cases because you see there's a small mass, you don't go check it up, it becomes cancerous. Little things like that. Or, so it depends on the area, the level of education. Now, in the northern part, culturally, you're not meant to cry. A woman is in pains, and you have to hold it until there's sepsis or there's something huge. So it's really different. Whereas in the western part of Nigeria, there's nothing wrong with you, but you're shouting, you're screaming. So it's really different. And what we need to do is understand what the culture is, and then educate, train, encourage women to speak out, because they stay at home with the children, with the family, and like you said, the more we can encourage them to have a voice, to speak out, to say this is not right, then there will be of better use to the population,
Well, on that, I think we'll end. I want to thank you so much for joining me here today. Thank you.
Much, Dr. Bembe, Dr. Romanzi. Obviously, we could spend multiple days talking about this topic. It's very enlightening and also very inspiring. As a next talk, we are going to have surgical care innovators in the spotlight. Please come with Ms. Sherry Reynolds. Sherry is the Director of Program Development at Assist International and an attorney. As part of her role as Assist International, she leads Innovations for Safe Surgery 2020 as a multi-partner initiative seed-funded by the GE Foundation, whose gigantic goal is to move the needle on surgical care for 50 million people by 2020. We also have here with us Mr. Hannington Segirinya. He's the country representative for Assist International in Tanzania. He implements the Safe Surgery 2020 innovation program that is tailored at improving surgeries in Tanzania. Welcome.
Thank you, Gustav. Thank you. We're very excited to be here.
Yeah, I'm excited too to be here. I'm Hannington Segirinya, as he has mentioned.
And we are part of the GE Foundation-sponsored Safe Surgery 2020 program that works to bring safe surgery to 50 million people by the year 2020.
Like many of you in this room, we also do believe that everyone, everywhere, should have access to safe surgical care. But right now, that's not the case.
Tonight, we want to tell you two stories, that show the difference between access to safe surgery for a woman in the United States where I live, as opposed to what a woman would face in Tanzania where Hannington lives. And while we know that there's a lot to celebrate in both countries, within surgery and outside surgery, there's still a lot of work that needs to be done. When I had my first child, I was fortunate enough to learn ahead of time that he was breech and that we would need a C-section. And the reason that I learned this was because I had 4 ultrasounds during my pregnancy.
In rural Tanzania, it's very hard for a woman to know way in advance that she will need a C-section, just because many healthy centers deep in the villages, do not have ultrasounds.
Because my C-section was scheduled, I never went into labor.
In rural Tanzania, since a woman usually doesn't know that her baby is breech, she goes into prolonged labor before she makes it to the nearest healthy center.
I remember the morning well. It was a leisurely morning. My husband and I were very excited. We got in our car. We drove to the hospital. We had family members waiting for us there.
In rural Tanzania, a woman would get public transportation, maybe a bus or a taxi or even a makeshift stretcher to get to a hospital. This can take even up to 2 days, and this is very, very dangerous because in most cases, a family would have to sell a goat or chickens in order to fund this.
My insurance covered everything except a $25 copay.
Once at a healthy center, a woman may be able to see an emergency surgical officer, but in most cases, there is no anesthetist or there is no oxygen for a C-section, and this puts her life in danger and the baby's life too.
When I arrived in the hospital, it did not even cross my mind that everything I needed for that C-section would be ready. The surgeon was there, the anesthesiologist was there, oxygen, all the medicine. Everything I needed was there.
If a woman is fortunate enough to have an anesthetist on duty, this will be typically a person probably who has taken 12 months training and earns about $2,000 a year.
An anesthesiologist in the United States has 12 years of training and a starting salary of over $200,000 every year.
In Tanzania, approximately 546 women will die, out of 100,000, will die giving birth.
In the United States, while the number is rising, still only 26 out of every 100,000 mothers will die during childbirth. And this is a huge problem that kills 17 million people every year. That's 1.4 million people every month that die, or 46,575 people each and every day that die because they don't have access to safe surgical care. And these are not just statistics, but these are real people. They're mothers, their fathers, their sons, and their daughters. And they matter. And we know that we have to all come together if we want to close the gaps in surgical care. We know that we can't do it alone, and there's huge gaps that are there that need to be addressed. We can't replicate what works in the United States, but really we need to leapfrog over current methods and devise new ways to close the gaps in surgical care. We have to come together as a global community to solve this huge problem.
In Tanzania, we also do believe that we cannot work alone without engaging our local partners. At Safe Surgery 2020, we work with the local partners and we innovate around 4 key areas. Around people, our Safe Surgery 2020 partner, Japaigo, they're doing leadership trainings to surgical teams in rural areas to communicate better, to be good at what they do, and find local solutions to their local problems.
And around processes, our partners, Lifebox, SPECT, WFSA, they're working on teaching hospital staff on safe surgical and sterilization procedures and how to handle the obstetric emergency. And we're exploring ways to solidify those trainings through remote mentorship.
Around technology, we are exploring ways of bringing safer surgical training to rural healthy centers through the use of mobile phones and applications, tablet applications.
And around business models, we're exploring how to move away from grant funding towards self-sustaining models.
One way we have been able to look at a serious problem is through our oxygen social business enterprise model. Access to oxygen is a serious problem in so many places, and many of you know about this. And it impacts the hospital's ability to perform surgery. In so many rural areas, hospital staff must travel over 8 hours to take oxygen cylinders and have them refilled. This is costly, this is time-consuming. It takes them away from their primary goal of saving lives and being at the healthy center facilities. We worked with the local partners to create a solution to overcome this devastating problem. that not only delivers the oxygen to the door of a healthy clinic or a hospital, but also creates a business model that keeps the oxygen program operating long after we step away. And importantly, right now it's being funded by an impact investment. We place an oxygen plant at a regional referral hospital far away, somewhere in the middle of almost nowhere, that normally has problems to access oxygen. And then we then set up an oxygen business to run the oxygen plant, ensuring that the hospital staff do not waste a lot of time taking the oxygen cylinders to get oxygen, but rather they should spend this time providing healthcare and saving lives and doing away with the unnecessary deaths that happen at the health center facilities. So we do deliver the oxygen to the surrounding hospitals and the health clinics at an affordable rate. So the money or the profits from the sales, they do come back into the business to pay for the maintenance, the supplies, all the costs that are involved around that. And then we have seen a tremendous increase in the amount of oxygen consumption by our partner hospitals where we are operating. And in certain areas, access to oxygen has been reduced from 3 days to just 3 hours. That's a great thing. Our model, we have proved this model in Rwanda and Kenya, and now we just started in Ethiopia, and we are looking forward to the great impact there. Increased oxygen means that newborns are being saved, trauma patients are getting treatment, and surgeries are being performed at the health center facilities where we operate.
There's still so much that needs to be done to fill the huge gaps that are there in surgical care. We need to come together as a global community. We need to advocate for access to safe surgery as a part of universal health coverage. There's no global funding for safe surgery, and that needs to change. We know that if we all work together and come together to view safe surgery as an integral part of a strong healthcare system, we can work together so that everyone, everywhere, has access to safe surgical care, so that every mother around this world has access to that same safe C-section that I had years ago, ensuring that her life and her baby's life can be saved. Thank you.
Thank you.
Thank you very much. That was absolutely fascinating. To continue moving forward, we would like to invite our panelists. So let me read one by one, to start with Her Excellency, Madam President, former President of Chile, the distinguished Michelle Bachelet, Dr. She's also the chair of the Partnership for Maternal, Newborn, and Child Health. I would like to introduce and call also Dr. Edna Aidan, founder and director of the Edna Aidan Maternity Hospital, former Foreign Minister of Somaliland and First Lady of Somalia. I would like to invite also Dr. Mpoki Ulisubisha, Permanent Secretary, Tanzanian Ministry of Health, Community Development, Gender, Elderly, and Children. Ms. Terry Bressenham, Chief Innovation Officer, GE Healthcare. And finally, our panel moderator, Dr. Atul Wagande, surgeon, writer, public health expert, and executive director, Adrienne Labs, chairman, Lifebox. Before to start, as our panel gets comfortable, I would like to ask Dr. Wagande to share his perspectives in terms of surgery in the context of universal and national health coverage.
Thank you, and it's a wonderful chance to get to talk with this panel and set a little bit of the stage here. Public health and universal health coverage are based on a basic principle, and that is that all lives are of equal worth. Now, what that means is that all of us around the world are equally deserving of the capabilities that the last century of science has provided that has doubled the human lifespan. When it doubled the human lifespan, when you have access to a regular source of care for the majority of your medical needs, when you're able to afford your needed medications and treatments that come from having access to that regular source of care, and when that care is also given safely. Now, what happens is that those who, that being able to have access to that kind of care means having a few basic systems in place. Primary health care coverage, labor and delivery capability, pharmacy, diagnostics, oxygen supply, and surgery. And it's only been in recent years that we've begun to understand surgery is not a luxury. Surgery is an indispensable part of getting to live a long and healthy life. No one, almost no one around the world, escapes the need, whether it's in an emergency obstetrics, where you need access to C-section, or it's a laparotomy, or treatment of an appendicitis, or care for a disabling hernia, or cataract to address incipient blindness. I got to be part of the DCP3, the Disease Control Priorities Project, in its third iteration, where we looked at what the highest value of public health provision is. And what we found was that investment in the first level capacity for 44 essential surgical procedures, so having the basic setup in hospitals for 44 essential surgical procedures, was as cost-effective as childhood vaccination. And we'd not recognized that importance. The Lancet Commission, a couple of years ago now, established through evidence that it's 5 billion people in the world who lack access to safe, affordable surgical care. And one of the things that that commission helped quantify was it was not only about the 5 billion who lacked the access, it was also about those who couldn't afford it. Because in addition to the people who simply didn't get access to the care, you had 33 million people a year who got access to care, but it was greater than 40% of their income, which is the definition of a catastrophic healthcare expenditure. Now, what we've been talking about can seem like an impossible agenda. How can we get to the potential of providing access to care when the gaps that we just discussed can be so deep? We just heard about the case in Tanzania. But we have seen across multiple places how this gap gets closed. And I've gotten to see it in my lifetime. I grew up, I'm the son of Indian immigrant doctors, to rural Ohio. And the county we were in was the poorest county in Ohio in the early 1970s. My father, a surgeon, went there as one of the first 2 surgeons to arrive in this community at a time when chloroform and ether anesthesia was still the primary form of anesthesia provided in the early 1970s through untrained providers in the United States. 1983 was the first time we had our first trained anesthesiologist in my county of 200,000 people. Now, how did this happen? It was directly because in 1965, we passed a coverage program that allowed people under the poverty line with Medicaid to get access to care. And in that county, that was how my father, a surgeon, and my mother, a pediatrician, came to provide that care. 1977, Korea, South Korea. Now, the US passed that law when it was at more than $20,000 GDP per capita. South Korea, at $10,000 GDP per capita, in 1977 passed they were only at $4,000 US GDP per capita, passed universal health coverage and implemented it before they'd even reached $10,000 GDP per capita. And they went from a place that had barely any access to the point that actually now their biggest problem we're struggling with is overuse of surgery across parts of South Korea. And then I got to see in the village where my father comes from, in rural Maharashtra, that with the passage of a program called RSBY, a below poverty line initiative that provides coverage to people, that people got their BPL card that provided access to about 40 essential surgical procedures. Now, this is a rural community, and the first anesthesiologist arrived within 3 years afterwards. His name is Shrikant Jaiswal, and I met him. 26 years old, and like my father, came with his wife, only she was a trained obstetrician gynecologist, and they provided the first surgical capability for that community, and then it attracted an orthopedic surgeon and a second obstetrician gynecologist. And in the district, where there had been only 8 surgeons now, there are now 120 different kinds of surgeons serving more than 2 million people, because financial coverage increases access and accelerates training and the capacity to make these things happen. Now, the second thing is there's a pattern, which is that the capacity that financing provides, that capacity growth, outpaces the quality. So surgery in the highest income parts of the world has a 1% or lower mortality in inpatient surgery. But in middle income countries, it's 3 to 20% that's been measured, and it's pretty much unmeasured at large scale in the lower income settings. But we know that we have more than 9 million dead or disabled each year from preventable complications from surgical care. There are safety gaps in every country, and we've also shown how it's solvable. This is the 10th anniversary of the WHO Safe Surgery Checklist that I was lucky enough to be part of, and a number of you here have been part of that. And in that work, it was developed around the biggest killers in surgery, ensuring the basics of safe anesthesia, infection prevention, bleeding management, and teamwork, probably the most powerful part, creating genuine teamwork. Through a 2-minute checklist of a team communication before anesthesia, before incision, and before the patient leaves the room. It was able to be implemented in 8 cities around the world, from Ifakara, Tanzania.
That's right. That's right.
To Seattle, Washington. From Amman, Jordan, to Auckland, New Zealand. From Manila to London. And across every hospital, rich, middle income, poor, there was a reduction in complications. The average reduction in complications was 35%. The reduction in deaths was 47%. And we have since taken it to large scale in high-income countries, seeing places like Scotland, France, South Carolina, demonstrating 20 to 30% reductions in mortality. And then in places ranging from Moldova to Uganda, showing that we're able to replicate similar kinds of results. Only with programs like Lifebox in partnership with the World Federation of Societies of Anesthesia and many other critical partners, we've been able to bring 18,000 pulse oximeters, so monitors of basic condition of the patient, covering 95% of the operating rooms in 25 countries. We've been able to have 6,000 anesthesia providers trained, and worldwide we're past 100 million of the world's 300 million operations are done with the basic WHO Safe Surgery Checklist. So do not tell us that this cannot be on the agenda. Do not tell us that this cannot be done. We have a remarkable panel of people to help us talk about how it's done and where we have to go and the challenges along the way. And I want to start with Dr. Adan. So people still don't see the connection between surgery, public health, and the gaps along the way. Can you tell me and the audience about the connections that you see in Somaliland and in the hospital that you have now built over the last 16 years, the Edna Adan Hospital, and what's the importance and the role you're finding there?
Well, I think, as you've said, everything is interconnected. Starting from the basic education of the community. I come from Somaliland, a country that is not even on your map, and a country that has survived 11 years of civil war. And in 1997, when I retired from WHO, my parent organization that I served with pride and dignity and honor for 32 years, I went home to my country where everything had been leveled to the ground. No hospitals, no facilities for surgery, no maternity care, no doctors. Well, at least there were 17 doctors in the entire country with 4 million population. And I decided that, well, since I'm a nurse, I'm a midwife, and the problem was so huge, I would start with the area that I knew the most about, an area in which I had been working all my life, and where I saw the greatest need. I would start a maternity hospital. Of course, I'm a woman in a country where women are not expected to do anything, and why do you want to build a hospital? You're a woman, how can you? Well, I will not build it, but I'm not a mason, I'm not a carpenter, but I will build it. But why don't you let a man do it? Well, I wish there had been a man to do it. Anyway, so I built what I thought would be a maternity hospital, where I would provide just basic maternity care. I soon realized that maternity does not start and finish as maternity. There's surgery involved. There's blood bank involved. There's oxygen needed. There's nursing care. There's post-operative, post-delivery, postnatal care. There's resuscitation of a newborn baby. So what I did was I started to train my nurses. While the hospital was being built, I started training the nurses. We had 4 technicians, anesthetists, who had no nursing background, who had no medical background, but who had worked with the militia in the war to do amputations and who were just shown how to do a ketamine. But this was not safe surgery. They could not give us a spinal anesthesia. They could not intubate. And we needed anesthetists who would save the woman, not kill her. So I set out my appeal to the world. And if that hospital carries my name, it is the entire world that is carrying it with me. And there are many, many countries and people sitting here. Dr. Laura Romanzi has operated on hundreds of women who needed surgery for fistula. I have Dr. Jani here, Koseksa, who's training surgeons for me. I have WHO sitting here, who continues to give me my pension. I see we get sutures. So I went to my neighboring country, and I said, I come from a country, Mr. Prime Minister of Ethiopia, where I don't have a single anesthetist, and I need your help. I said, well, what can I do for you? I said, could you train those 4 technicians that I have in your hospitals in Ethiopia so they can see what anesthesia really means? So that's where I got my first anesthetist trained for 2 months each, because we cannot spare them for longer. But they came back with better skills than they had before they went there. Following that, we started to train nurses who had knowledge of the human body, anatomy, physiology, and trained them with the support of Kenyan anesthesia trainers. Today we have 31 anesthetists and surgeons like Dr. Laura Romanzi do not need to bring an anesthetist with them when they come to operate. That being so, then we have the oxygen. We need oxygen. People would kindly donate a pulse oximeter or an oxygen concentrator. I don't have electricity most of the time. So what am I going to do with an oxygen concentrator when I have no electricity? which means that we sometimes send our empty cylinders to neighboring Ethiopia. And I was happy to see the pictures and on the donkey cart. When their empty cylinders go out, when they're full, they don't cross the border because they're considered explosive and they're considered dangerous. So by trying to get oxygen cylinders refilled in another country, I lose them. Now, if I have the blood bank and the oxygen and the operating theaters and the anesthetists, I still need a consent, someone to approve for us to operate on this woman. And very often a man would say, but her mother had 10 children, her sister had 15 children, none of them had C-sections. Why do you want to operate on my wife? I said, well, luckily your sisters and your brother's wife did not need it, but your wife needs it because her baby is lying sideways or a placenta is there before the baby. And if we do not operate, she will die. He would immediately think that I need money from him. But he doesn't know that I do emergency C-sections for free. And even if we charged him, we would be charging them $200. So for me, it costs me more to do a cesarean section because we do it for free. But I have a living woman at the end of the day. When we have the consent from the husband, then I will also have the father of this woman come to me and say, the husband has authority over the baby, but I have the authority over what happens to my daughter. So if the husband has signed the consent, I have not signed for this operation. So I again have to explain. And sometimes I just go to the police station next door and I say, look, we don't have time. The woman is bleeding, the baby is dying. You don't want to sign an approval for the surgery, then please sign this paper on the other side and say, I want my wife to die. Sign it in front of the policeman. It's your wife, it's the mother of your children. So we don't have time, it's your wife. So anyway, these are the obstacles
She's just talking about last week.
We also talk about women who live right across a couple of streets from the hospital, who will come to us with an obstructed labor, who will come with a ruptured uterus, and who were not brought to the hospital because nobody believed that we could save her. Today we have a hospital where we have female surgeons, thanks to trainers like Dr. Laura Romanzi and others, women assistant surgeons, women anesthetists, women instrument nurses in a hospital built by an old woman who everybody thought could not build that hospital and could not finish it. And the message that I want to leave with the world today is if we can do it in Somaliland, and if we can bring the maternal mortality of the women who come to our hospital, which is a major referral hospital, we've delivered over 22,000 in the past 16 years, and we've lost 63 women. It's a lot, but it's a quarter of the national average. And if Somaliland can do it, anybody can do it. Just find a crazy old woman to do it. We're still losing. Just give me one more minute. I'm 80 years old. I'm going to ask for one more minute. The best way to fight, for better care for our people, better surgery, better obstetrical care, is to educate the women. And that's where the last connection comes in. If you don't educate the community, and if you don't win their trust and their confidence, and you don't have the necessary resources in place and prove that you can provide safe surgery, we will never go forward. So everything is interconnected, and education is the best gift I wish to leave for my people. And I know I will be leaving soon. I'm 80 years old, no need to calculate. Education, community, ministers, governments. Can I leave one more challenge? My challenge to the world is, if we want to save the lives of our women and our children, and I would like WHO to champion that, is to countries with high mortality rates to allocate 0.001% of their GDP specifically for safe surgery and safe obstetric care. And if our women and our children are not worth 0.001%, then we're not worth anything at all. We need to allocate funds. Thank you.
President Bachelet, she set you up beautifully because the interconnections of establishing maternity programs ended up leading to surgical care, ended up leading to building the capability of the system as a whole. People often don't know, but you are a surgeon, president of Chile, and now in this new role as chair of the Partnership for Maternal and Newborn Child Health. And I want you to put your surgeon's hat on a little bit here to say why a surgeon decided that this maternal child health partnership would be the connection that you see. How is the work of the safe surgery effort aligned with your global strategy in PMNCH?
Well, first of all, from all what we have heard, we know that safe surgery care is a human right. And that inequality is behind all the bad consequences, because we saw the difference between the US and Tanzania, but we know it from all kinds of difficulties in many places of the world. In Latin America, in some countries are in very good position, some other in very bad position. But the majority of these cases, many affect disproportionately women. There are some data that I would like to share with you. 5% of pregnancies require emergency obstetric care, but few have access. What does it mean? 300,000 deaths a year. And as one of you mentioned, we're not talking about numbers. We're talking about people with families, named faces. Obstetrical labor is responsible for 9% of all maternal deaths every year. And also, untreated obstetric fistula affects 2 to 3 million women, and maybe they don't die. Some of them can die because of infections and so on, but it means social stigma and loneliness, because the majority are abandoned by the families. So I think that it's so important, and of course, child can die in a birth that is not well done and so on. So I believe that we need to work together in terms of ensuring that safe surgical care is considered a human right and be addressed like that. What we should do about it? What can we do about it? What we can try to do about it? Well, first of all, I think we have to partner much more with G4. And we have some opportunities because the partnership is a platform that has 1,000 people and 10 constituencies. And part of those constituencies are FIGO, the International Federation of Obstetrics and Gynecologists, also the International of Pediatricians and International Federation of Midwiferys. I am a great fan of midwiferys. In my country, midwives have been a great solution to many of these problems. And I think we have also to try to do our best, even though it's very difficult, a recipe, to get to global leaders, to presidents, to prime ministers, of course to Minister of Health. But the Minister of Health understands this. You need to get to the Minister of Finance, to the Minister, or to the President or the Prime Minister, and we cannot take them to the police. We need to try to convince them. And I think that can be done through information, education, but we need also to do it because many of these expenditures don't have a short-term result. And I'm not going to say anything. I'm a different person because I'm a doctor, so I really understand these things. But for many politicians, they don't like long-term results. They want short-term results because the election will be in 4 or 6 years. So I think we need to show them the data. We need to organize people, organize women, educate women, but also educate men So it's also, we work on the upside, but we also work bottom up. So people are asking, demanding the right to have safe surgical care. It's not an easy thing. It's not an easy either with finance ministers, because every sector is pushing them and every sector needs more. But we'll try to do our best as a partnership. We have a partners forum in December in New Delhi, and we will be there also putting this issue as an important issue. So you can count on us, but it's not an easy task, but we're going to be with you there.
Dr. Mpoki, one of the concrete strategies to work at that top level that Dr. Bachelet was talking about there is what we've called NSOPs, so the National Surgical Obstetric and Anesthesia Plans. So asking countries to develop their national plans for being able to start to close the gaps along the way. And your country in Tanzania has become one of the first to not only develop your NSOP, but then also to do the full costing of what is required. Can you tell us a little bit about what the elements are of your national plan?
Oh, thank you very much. I need to, at the outset, acknowledge the presence of my good friend, compatriot, Professor Jani, who presides over the College of Surgeons for East Central and Southern Africa. And he and I work so closely because I preside over the College of Anesthesiologists in the same region under the College of Health Sciences. The National Surgical Obstetric and Anesthesia Plan of our country was constructed out of the need to meet the conditions for the National Strategic Plan number 4 for health, which is built on nothing but the fundamental principles of health systems. So we have looked at this section of human resource for health. We've looked at the funding. We've looked at the infrastructure. We've looked at governance. We've looked at access to those services. And the digital platform, the information technology, making the sixth wing. So that is the foundation on which this National Surgical Obstetric Anesthesia Plan is built. I need to stress on the fact that no single National Surgical Obstetric Anesthesia Plan can fit the landscape of all nations in the world. Each country has to make their own, to customize it, to meet the particular needs. Meaning that one for Somaliland will address issues that are a problem to offer quality surgical services, be there for the obstetric patient or for the non-obstetric patient in that particular country. And I'm not sitting here to defend some of the errors that were made during the previous presentation for Tanzania, but I'm only dwelling on principles. So we have challenges that are very unique to our country. They've been addressed in the health policy, but they've also been articulated so well in the National Strategic Plan number 4 for health. So those must be brought about to provide key to the building blocks, addressing the challenges that we meet every day. Now, looking at a woman, our maternal mortality in our country, by the most recent demographic health survey, stands at 556 per 100,000. Now, for a population of 50 million, maybe that's a small number, but you know, that turns to about 11,000 women dying every year. I'm talking of women, I'm not talking of numbers. That was a clarion call that made us come down and look at ourselves. Where are we going wrong? We've invested a lot in human resource for health, infrastructure, health commodities, and even the systems themselves. With all the knowledge and evidence from current research, we should not have been having that big number. At one time, we even inquired, are the statisticians doing us a disfavor? Because we are not seeing the number of women amounting to 11,000 dying every year in Tanzania. However, we employed that number as a challenge to solutions. How are we going to cut down on this number? Now, we realized that the health infrastructure in Tanzania provides for services formally from dispensary at a village level, then to a health center, ward level, and then a district will give the hospital services. Then a region, and then a zone referral hospital, then the apex institutions in the country. In some places, the distance between the health facility, those are dispensaries, and the population could take even 20 kilometers. So we realized that could be a problem that we needed to address. While we were looking at the maternal complications, we also realized that other causes for surgical interventions were on the rise. You know, with big population, you expect those numbers to go up. So trauma, for instance, related accidents, causes of injuries that require surgical interventions. So the orthopedics had to come in, the neurosurgeons had to come in. All that need started from the dispensary. So we had to plan. That is what informed our position on the content of the National Surgical Obstetric and Anesthesia Plan. For the longest of time, we invested seriously on surgeons and obstetricians. Anesthesiologists, well, those who felt like studying anesthesia will go in. So for the longest of time, we had less than 10 in a country of about 40 million. Currently, as I'm making this presentation, we have about 32 anesthesiologists in a population of about 50 million. So we are long distance. So in between, there are those that are non-physician anesthesiologists or anesthetic service providers, nurses, clinic officers. All these have to be brought on board. So that is on the side of the human resource for health. Quality behind their training is a solution to provision of safe and effective anesthetic services. If you take somebody to a place where they're going to see people giving anesthetic services and bring them back, this is what Dr. Dan did not tell us because of the experience in her country. The end results are not going to be as satisfying as those that have gone through a didactic training program, where somebody is told why certain things are done in a certain way and not in another way, where people are warned against shortcuts. Shortcuts end up in shortcutting people's lives. And when people don't understand that, then they come with all sorts of things. When people are not trained properly, then they depend on one drug, ketamine, not knowing that there are better anesthetic agents that could provide better bridges during surgery with better outcomes. So all these things had to be considered when we were coming up with our National Surgical Obstetric and Anesthesia Plan. So for the improved services closer to the people in rural health centers, we put up buildings, yes. Health commodities, yes, but human resource for health is one that needs all the investment any person can do. We needed it then, we need it now, and we shall keep on needing it. And because the country is bigger than I can put in words, we've started with the most hard to reach, geographically challenging, but also areas that have bigger populations that would not benefit from a facility that existed that all went to find the services. We also made sure that human resource for health distribution will be geared according to need. Community health workers are not left out because they are going to help us encourage our people to develop health-seeking behavior, meaning that they'll come to our facilities early where we shall pick on possible complications early before they set in and they intervene. Now, other challenges that are non-systemic, those will be addressed as they come up, and those cannot be put in writing. So I thought of contextualizing our National Surgical Obstetric Anesthesia Plan in that fashion. Thank you so much.
I just want to put a pin in how radically different what he just described is from the way that public health has been carried out at large scale across the world. We have been, and we've talked about the fact that we've been in verticals, you know, that we're deploying an HIV program, a TB program, a malaria program, and so on. And we've been reluctant to talk about building out the systems themselves because it felt too difficult. It felt too complicated. But moving to the place where you break the system down into achievable chunks, you know, the surgical obstetric anesthesia plan, the primary health plan, and you begin recognizing that there are ways to make it work and that it's not investing willy-nilly here and there, but actually in discrete components that you can manage and follow over time as it grows. So I just, you know, it's incredible that Tanzania was one of the first to drive it and really make it become part of a national strategy and your overall health strategy, because that, I think, is the wave of the future. And with that in mind, I want to turn to Terry Bresnahan, who's the head of innovation for medical innovation at GE. And why then has GE, a very large corporation, decided to focus in this area? There has been no, as your colleagues pointed out, there's been no major global funder in this work, and GE is stepping up to begin to be the first to put your resources in that place. So why?
Well, I mean, having a conversation like this only re-energizes, in fact, why it's important to do this. Because we are far away from the destination we all want, which is safe, accessible surgery for everyone. I'm very fortunate to have a chance to work in a company that cares deeply about this, along with our colleagues in our G Foundation who also care deeply about this. As was stated earlier, there's an estimated, more than 5 billion people in the world who lack access to safe surgery. And there's no one in this room who would say that's an equitable handshake for people in the world, for things that we know how to solve. I mean, that's the other crime, if you will, that's here, is that we actually have the wherewithal to solve this problem. That being said, I think innovation in our way of thinking is kind of a set of concentric circles. In our world, we would start in the center, which is around technology. You heard from Gustavo, who leads our surgery business. We can take the way we think about these high-end technologies that have been applied in many parts of the developed economies and rethink that model and really significantly reduce the cost, because we know access is inextricably linked to affordability. Sure. If we don't change the cost structure, we will have limited how much access is going to be available. So that's our first order, if you will, problem to solve, is can we fundamentally disrupt the cost? And not just the upfront cost or the capital cost, but can we disrupt the ongoing operational costs of these systems, whether that's electricity or the consumables, and again, whether it's the case of the large-scale surgical equipment or whether it's the anesthesia machine or the monitoring systems or the pulse ox systems or the ultrasound systems. All of these things are important to take down that cost. I've also had the great fortune of living the last 7 years in India and working across Africa, India, and ASEAN, firsthand watching and seeing and experiencing what the relevance means. When we say innovation, it's a very different proposition when you're standing next to someone who hasn't had the benefit, all the conventional training that we might have seen, who is, in fact, resource constrained in many other ways. Their environment isn't the same. They have, less than ideal situations for dust and humidity and power and such. Well, you're not changing that overnight, so just design for that. So we're trying to think about all these components, costs as well as the applicability or relevance is the word I like to use, about how these systems need to operate. Outside of that, or the next circle around that, is all the other components that it might take to create that ecosystem for safe surgery when we think about technology. So things like oxygen supply, as was earlier mentioned. Our foundation has funded a number of startup ideas which could make oxygen supply readily available at the point of care. That's another fundamental problem, right? We think about the next circle, which is skills. If tomorrow we had magic pixie dust, the money was there, the infrastructure was there, we still would lack the available skills that deliver safe surgery, as you mentioned. That's another key area for what we believe in and what we're trying to invest in is how do we partner to develop the skills? Some of that even relates to task shifting. Can we take a less conventional person and train them in a narrow scope, for example, a nurse anesthetist? Can we take the rural youth out of the places where jobs are needed? Can we create new healthcare workers with different kinds of programs? And those are the ways we're trying to invest as well, which is skills development, fundamental to changing the outcomes here. And then lastly, we think about the overall wing-to-wing systems support structures that need to be in place. As you mentioned, it's not just about the activities that happen in a surgical suite, it's actually all the continuum that happens around that. If you really want better outcomes, you better think about the before and the after, or the left and the right of a surgical system, and I think that's another area, whether those are ways we can work with the skills development, whether those are ideas which connect digitally or virtually. We're looking at, like a post-surgical tele or virtual recovery model. I think there's plenty of ideas that we're working with, and I am really excited by. So, as a company, we're extremely committed on this. The G4 Alliance has been a real opportunity for us, I think, to help plug in on that. But I would kind of take us back to, again, we're doing all of this for only really, in the end, one outcome, which is make sure more people survive. In the course of this event alone, and I think women and children are disproportionately affected by this problem, as was already mentioned, but think about it, 830 women who give childbirth, or 830 women who are in active child delivery die every day. Or in another way to state that, in the course of this event, if I took the last 5 or 6 rows of this room, you're dead. It's just the time we spent here. That is an unacceptable figure because we know how to solve that. So I am really motivated. Our company is very motivated. We believe in the idea of this network or partnership is the only way it can be solved. No individual institution or company can solve this. And that's why the collaboration is so important. And I'll just lastly mention, it's not only the developing economy's problem. Last night on the stage, we celebrated and recognized 2 mothers who have fought for the right for surgery for scoliosis children in a very developed country. And I think that's another human right, that even when you have the capacity to serve, it may be denied. And I think that's another part of our overall mission as the World Health Organization, as the UN, as private sector. We have to fight for what's right. And this idea that health for all is not a notion, it's an absolute. And I think that's what we're here to help with.
I'm going to ask Gustavo, what's our timing for, at this point, should I? Okay, so we will, I'll just summarize by saying, I think what we've had a chance to hear across the course of the panel is that, number one, is that safe surgery is a basic part of getting to live a long and healthy life. Virtually everybody requires access to it. Second, that achieving the goal of having that access is a critical component, is achievable, and it's achievable through financial systems. And that universal health care coverage and access to coverage for the poor to surgery has become something that even a setting like India at $1,500 GDP per capita has been able to deploy through below poverty line programs and other things like that. Third, that you have basic quality programs like the Safe Surgery 2020 initiative, and the WHO Safe Surgery Checklist, the commitment of Lifebox, the World Federation of Societies of Anesthesia, and a number of other organizations have shown can be done. The fourth part is that national surgical obstetric and anesthesia plans are where they get integrated and customized to each individual country, and it's our first opportunity to really have plans at the policy level about how you're building out your systems of care and not just disease-based verticals. And then finally, that this is a core necessity of every major actor in the system, the NGOs, the governments, the corporations, and the citizen groups, the public mobilization that we're going to require. So I thank all of you for joining. I thank this panel for a terrific overview and appreciate all of your commitment to making it happen.
Thank you very much. It has been extraordinary. I hope that everybody has enjoyed. We are going to ask you to hold 5 more minutes before the cocktail. We are going to have a short video for safe surgery for women. The patient experience is 5 minutes, and then we'll have some closing remarks from the ambassador. Thank you.
عندي من قد لا قرية دتها لا موتا سألنا هسبتال سأل بحرسي من قد لا قرية ترحق أين ري مجعون لها ترحق كما جعون تخلا تقدمت لي شو عاد عمتها تشملت خدله أم بشع هاي ولدنا يعني ما راح نتصلحوا أكو صح السنة عيت ودي بما تعبها طيب أو بأفا أو مصاحتهم لج ولا بأف سلمتس بمحصن حوتي عبي حفتي معراي بكرة عبي حفتي دوري كأو أوبريشن تخوني أنا نفرم ما تقولي أفرمي ولا عبي أنا لا بقى كموتي إلا هو أي ذخيت موتي أميتي كوا أوبريشن قبره وقال حقفهم كل أخوني ولا ذا معراي تبرتني أنا برمكم خد أخوني أو الدم أخوان دوك أي زخيت فرحت عم بيخجن تموتي ولما كأشيا أمننا فرم كأشيا فرم كفر أوسع فرق ساعتي وأنا جاوب برخو كوز لبس حساي نارني أنزله يتفلت كاستي لو قعني رهيل لي أنا قرنا أجاوتنا نقول بقى شو أجاوتني أدور أتفلتني هم دقيرن تفلتني شيء حرب قلع برأه الحرب رو بنا سمع عنده حر أتفلت إنها مبورة ممدوق صوّه همي من ما قرأت تفلت شو قولي معده همزنا أتي سلامنا أتي قلع حصري خطوط سلام شكري ولي حتى يا ردا أنا ولا أحس طلع من شكري ولي دستا كاسوا دستا أصدعني يبدأ حقوسي دستا كخال أي ثوت بقى بفترة مني هم بحدث فترة خي بس سمعني
Ladies and gentlemen, you know, sometimes when I see these videos, it really reminds me, as it should remind all of us, why we do what we do and why we should continue doing the work that we do. You know, I was saying to Walt earlier, we are all leaders in this room, and our job as leaders is to make this world a better place than we met it. And the very small contributions each one of us make in a cause such as this really leaves this world a better place than we met it. And I congratulate all of you, all heads, all hearts, all hands on deck, who are making this work, this type of work possible. We heard some excellent comments that highlighted women's leadership in global health. We heard of the issues of scaling up and models to halt, if not reverse, the movement of skilled labor. We have heard of an opportunity contrast in relation to access to safe, essential, affordable surgical care. We ended with a wonderful panel that highlighted the issues of education, of resource allocation, if not reallocation, the political, the policy work that needs to be done to bring positive influence into this space. We have heard of the customization of the nuance and soaps and the work that's been done in Tanzania. And I was happy to hear of the private sector disruption of the cost models and the innovation required around skills development, among others. Ladies and gentlemen, this is about cooperation. It's about collaboration, if not collusion, as we galvanize around this theme of providing safe surgical care to those in need, particularly for women. You know, there's an old adage that says, a surgeon is as good as her last surgery. I would argue a leader is as good as her last cause. This is a wonderful cause, and I implore all of you to rally around it. I thank you for coming. I thank you for leading. And I wish to thank you for accepting the invitation to be part of Global Surgery, a powerful strategy for advancing women's health. And I wish to invite you to participate in a local reception, a powerful strategy for advancing fluid conversation outside. Enjoy the rest of your evening. Thank you.